Today we'll discuss atrial fibrillation and anticoagulation, the use of NOACs versus warfarin in post-cardiac surgery patients. It's a very important topic as the prevalence of atrial fibrillation is very common. The post-operative atrial fibrillation is common after cardiac surgery, and the incidence varies with the type of the surgical procedure, ranging for about 30% after coronary artery bypass graft surgery and up to 45% after the valve surgery. Multiple studies in the literature have been linked to post-operative atrial fibrillation to adverse perioperative and long-term outcomes, including the increased risk of cerebrovascular events. Oral anticoagulation therapy has been shown to be associated with improved outcomes of post-operative atrial fibrillation. The contemporary US and European atrial fibrillation guidelines recommend the initiation of oral anticoagulation therapy for post-operative atrial fibrillation in individuals with elevated stroke risk, and acceptable bleeding risk is class 2 and the level of evidence is B. Based on these findings of the recent randomized controlled trials, non-vitamin K antagonist oral anticoagulants have become the first line of therapy in preference to warfarin for systemic thromboembolism prophylaxis in individuals with non-valvular atrial fibrillation. These clinical trials exclude the patient from the post-operative atrial fibrillation, leaving the choice of the optimal anticoagulant to be unresolved, despite the gradual increase in the prescription rate of NOACs for post-operative atrial fibrillation. Warfarin remains the most commonly used anticoagulant. We sought to test the hypothesis and by various trials and still ongoing in the research. So the most important complication which atrial fibrillation can happen with atrial fibrillation is stroke. Patients with AF can have 5-fold higher stroke risk than those without AF, and it doubles the risk of a stroke when adjusted on other risk factors. And 1 in 20 patients with AF will have a stroke, and estimated 15% of the strokes are caused by AF, and as compared to 12,500 strokes per year in England are attributed directly to atrial fibrillation. And this is a diagrammatic representation of the clot in the left atrium and migrating through the common carotid artery and going to internal carotid and affect the portion of the brain. So the 20% of the strokes are fatal, and as compared to non-AF strokes, 70% increases the hospital mortality and 40% decrease in the chance of discharge home and 20% increase in the length of the hospital stay. Warfarin reduces the relative risk of a stroke in approximately 65%, and the primary stroke absolute risk reduction is 2.7%, secondary stroke reduction is 8.4%. The numbers needed to treat in 1 year prevent stroke: primary is 37, secondary stroke is 12, overall is 25%. Studies shows NOACs to be at least as effective as probably more effective than warfarin at stroke and in reduction of the AF. The studies are still going on, and the rates of short-term adverse event are similar in warfarin and NOACs group in several studies, and it's NOACs significantly lower the 30-day myocardial infarction, VT, and non-significant reduction in the stroke and TIA. The cardiovascular effects of anticoagulation post-cardiac atrial fibrillation accompanied by higher rate of bleeding complication. However, some studies have shown that there is a decreased risk of stroke and driven by reduction in the hemorrhagic stroke, improved survival as compared to warfarin. A limited number of studies have attempted to examine the safety and efficacy of NOACs for atrial fibrillation following cardiac surgery, and in one study, the new onset of AF, they found no difference in the stroke or bleeding and complication rate based on the oral therapy. The choice of optimal oral anticoagulant is further complicated by concomitant indications of antiplatelet therapy. Recently, Augustus study trial demonstrated that the patient with atrial fibrillation with percutaneous coronary intervention who have the primary indications for P2Y12 inhibitor therapy, NOACs, were associated with similar efficacy and fewer bleeding complications as compared to warfarin, and that warfarin combined with dual antiplatelet therapy was associated with a higher risk of bleeding complications. Similarly, the patient with acute coronary syndrome who undergo CABG have class 1 indication for dual and antiplatelet therapy with addition of P2Y12 inhibitor for 12 months. Although the previous studies have demonstrated significant heterogeneity in implications of these guidelines recommendation, the patient treated with CABG for acute coronary syndrome who develop atrial fibrillation are prescribed with oral anticoagulant were less likely to be prescribed PY212 inhibitors as compared to those prescribed with oral anticoagulation. It is likely related to concerns of increased bleeding risk with combination of P2Y12 inhibitors as oral anticoagulation. Unfortunately, the prospective studies are needed to determine the optimal antiplatelet anticoagulant regime in the patient for acute coronary syndrome undergoing cardiac surgery who develop atrial fibrillations. So this is one of the studies which compares rivaroxaban and warfarin, and these are the pathways. And rivaroxaban, as you can understand with the name Rivaro and 10A ban, so it's a 10A inhibitor, and dabigatran is working on thrombin. There is no role for aspirin in the treatment of AF, but as we have discussed, that it can be used as a dual antiplatelet therapy. There is a CHADS score which is used to quantify the severity of atrial fibrillation, and the stroke rates are described here, and the NICE guidelines describing the CHADS score for the patient. And there is another system of classification called as HAS-BLED score. NICE guidelines has in 2014 demonstrated the use of apixaban and other NOACs. So which anticoagulants? Warfarin pros and cons. Warfarin has been prescribed for more than 50 years. It's a long tested things, and we know the complications, embryopathy, and their effects. And it is difficult to monitor, and a poor INR control is associated with increased morbidity and mortality. And there's a review of the NICE guidelines of atrial fibrillation. NOACs are well tolerated than warfarin. They are fixed dosing regime and few advantages. Shorter half-life, and there is no antidote. That's a problem for NOACs. and people say that NOACs have a lower risk of intracranial bleed. The renal function needs to be monitored, and there is a dosing criteria. And safe prescribing is needed, and routine monitoring of the renal function, hemoglobin, and counseling is required with the use of NOACs. And there are several drugs which can have interactions with NOACs. And switching to the NOACs, one need to attain concomitantly the INR is more than 2, and missed doses should not be forgotten. And there are few things which needs to be discussed, and compliance, Medidose, domiciliary patients, and GP pharmacy communication are important. Hope you have enjoyed this presentation. Thank you very much.